oxygen tank. So basically we have the cylinder itself and we have the regulator. Now on the regulator it's really important to make sure the Botox seal is intact and that it's not leaking. So we want to place this on the middle part in the regulator. Then what we want to do is put the prongs in the pillar valve. So there's 3 little holes and they should match up to make sure we've got the right regulator. So I'm just going to tighten it on, and once it's to the cylinder, you do it a quarter turn. So now that that's nice and secure, what we want to do is we want to turn the cylinder on and make sure that there is pressure in the cylinder. Then we want to just check that the valve is working and oxygen is flowing nice and easily. We give oxygen when it's indicated that a person's oxygen saturation or SpO2 is less than 94%. This could be indicated by stridor, rales or wheezes. We also give it if there's airway obstructions, respiratory distress, shock, carbon monoxide poisoning and smoke inhalation. Non-rebreather mask. So this delivers 90% oxygen at 10 litres per minute. So I'm just going to attach the tubing that's already connected to the cylinder. I'm going to turn that up to 10 litres per minute, making sure that the bag is filling, and then putting it over the patient's face, making sure it's not catching on the ears, making sure it's over the nose, and we've got a tight seal. So now I'm going to show you how to take the regulator off the cylinder. So first of all we want to turn it off. So we want to righty to tighty. Awesome, and then we want to release the air that is trapped in this regulator. So we do this by turning on the dial and it should turn off like that. So now I'm going to talk about the bag valve mask. So what we want to do is we want to make sure that our equipment is working again. So we've got our reservoir here. I'm just going to check the filters are working in here. Now when we place this one on, if it's really loud, we know that there's probably a break in the seal, so we need to just get a new one and then placing the mask over it. So we've already done a chin lift and inserted an OPA to keep the airway open. And what we want to do is we want to turn on the oxygen cylinder and putting a flow rate of between 10 and 15 so that we can deliver 98% oxygen. We want to be ventilating every 5 to 8 seconds. So we place the mask on with a CE grip, and we want to watch the chest rise and see for any gastric inflation. Now if there's too much gastric inflation, we can get a second person to help us by applying cricoid pressure, and this basically reduces the gastric inflation. Today I'm going to be using the rigid catheter, and just to note there is a second catheter we can use which is a soft one. So what we want to be doing is putting the patient into a lateral position, and then we want to test the suction unit. So we want to turn it on to full blast and just occlude the suction unit, and we want to watch the lights go up. So that's fully working. So next we want to make sure that we are just doing circular motions out, making sure that we're doing it for no longer than 10 seconds. So I'll just turn this on. And we close to suction on this little dot here. So going in, and then we suction on the way out. Going in, suction on the way out. Now, there are some complications however, and that could be things like vomiting, bradycardia, hypoxia, aspiration, soft tissue trauma, and some laryngospasms. Measuring up the oropharyngeal airway. Now this is used for patients who have a Glasgow Coma scale of under 8 or a verbal response of under 2. So this is basically to open up the airway and create a smooth oxygen delivery flow for those who are spontaneously breathing and not getting enough oxygen. So what we want to do is we first want to measure up. Now it's important that we get the right size, because if we have it too big it can induce vomiting with the gag reflex, and if it is too small it can basically cause another obstruction without getting the tongue out of the way, which is the main reason why we use these. So we want to measure it from the corner of the mouth down to the bottom of the mandible, and we want to start by doing this is we want to make sure that the chin is tilted up, and we want to put it in 180 degrees, and then once we get down to the oropharynx we want to twist it another 180 degrees. This basically lifts the tongue off the back of the throat, and we want to just double check afterwards that he's or she has accepted it. We just checked, then have a look to make sure it's in there nicely. This is the nasopharyngeal airway, or NPA airway, and this one is inserted to the nose. So what we want to do is we want to measure it up like the OPA airway. So we want to go from, this time, from the middle of the nose down to the earlobe, and as you can see this is a nice fit. So what you want to do is choose the larger nostril. You want to get a water-based lubricant, and you want to just lube up the tube. What you want to do is then you want to insert it 90 degrees and twist it around 180 degrees if you hit any obstructions on the way through. Now this has some advantages. You can use it when a person has a gag reflex and you can't put in an OPA airway. Also if someone has a higher GCS than when you use an OPA airway, and if they have lockjaw or trismus. Also there are some contraindications, so if somebody has a suspected skull fracture, you would not use this, and it can also result in nasal polyps or nasal bleeding. So this is the LifePak 15, and we're just going to demonstrate how we use it today. So first of all we want to turn it on, and we want to put it into manual mode. So we press the energy select button, we click it round to yes, select that, and then just go away from that by using the home screen button. So next thing we want to do is we want to do a user test. So we press options, scroll down to user test, and whilst that's doing that we just want to make sure we've got our SpO2 and our CO2 leads. We've got our ECG leads hooked up there, our non-invasive blood pressure cuff is in the top here, our spare roll of paper. We can also check our batteries, and we can see that they're full back here, and we can also see how much they've got on them on these two here. We also want to just double check that we've got some defib pads, aspirin and GTN if we need it as well. So this is the user test, and it says that it's passed and it's got the correct date and time on it. So next we want to do a test load, so we want to go to energy select, turn it down to 50, select that and charge. Then we want to press shock. Then we also want to charge it again, and if we wanted to disarm it, we just press the middle of the selector knob. So now moving on, we can change the leads that we want, and select that. We can also press size. We'll just turn the ECG simulator on. So we've got a normal sinus rhythm on here. We can change the size of the ECG, so we can turn it up, or we can turn it down, but it usually sits on 1.0, so we'll just leave it on that for now. We also want to check the QRS volume, so we use the selection knob to find the heart rate, select that again, and we can turn the QRS volume up, or we can turn it down to your choosing. We also just want to note that if we were to do a non-invasive blood pressure, that the cuff is in the back, and that we press the NIBP button. We also just want to check the roll of paper, so we make sure it's full, and if needs be we can take it out and replace it. And we also just want to check that it's printing properly, so we just press print. And that's that. So now we just want to finally check and put it into AED mode again. So we just press the Analyze button,
Analyzing
and
now.
Put it into AED
Stand
mode.
clear.
So now we're going to do a respiratory assessment. So we want to be looking for chest or abdominal rise for 10 seconds, and we want to see if we can get a rest rate between 12 and 20 respirations per minute. So I've got Nadine here, and she's already given me consent to do this. So also I want to be looking out for any rales, wheezes, stridor or crackles. So I'm just going to observe that for 10 seconds. So. Lovely. So she's got a rest rate of 12, which is within our normal parameters. We also want to, when we're doing that, just check for the volume and depth of that they're breathing. We don't want them to be breathing too shallow or too deep. So it was just normal rise and fall there. We also just want to check on the mid-auxiliary line, on the the top and bottom lobes of the lungs. So I'm just going to listen to your lungs now, and I'm just going to be putting the stethoscope on your skin and lifting up your shirt, okay? Let's get a deep breath in, please. And out. Then the same on the other side. In. And out. Cool. Just going underneath again now. Breathe in. And out. Cool. And one more. Awesome. Now what we want to do is we want to check how many words per breath our patient can do. So can I get you to count to 10, please?
So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
And we can just assess by that how much they need their oxygen. We also want to do an SpO2, so we have a monitor here. Can I just have your finger? So we put this on their finger, and the machine will do the work and figure out what the SpO2 is. We also just want to look at the positioning of the patient. They're not hunched over or in a tripod position, really using excessive use of the body muscles. There's no nasal flaring, and she's not cyanosed also. So she has a nice perfusion of 97% oxygen saturation level, which we normally want over 94%, otherwise they should be getting some oxygen delivery of some form. And whatever we do find out, we do want to record it either on our glove and then transfer it onto a PRF or straight onto a PRF. So now I'm going to just check for a blood pressure on my patient. So this is Nadine. Is it okay if I just take your blood pressure?
Yep, that's fine.
So first of all, we want to remove the clothing from the area. We also want to then just measure it against the arm, making sure that it is at least 2/3 of the arm, okay? So we want to, if you can just hold these for a moment, please. Awesome. Make sure that we place the blood pressure cuff in the right area. And we want to just see if there's a pulse. So I can get a faint pulse there. So I'm just going to place this on top of here. So what we want to look for is the first beat that we hear that comes back as a real loud boom is our systolic number, so that's the top number. And then the one that we hear last before it fades out is the diastolic one. So I'm just going to put my stethoscope on and place my stethoscope on the medial side of the inner elbow. Okay, so I'm just going to pump this up, okay, Nadine, so it will go a little bit tight. To the point that you can't hear a pulse coming through, and slowly release. And I fully release, and I got 118/76. Be taking Nadine's pulse here, so do you mind if I just take your pulse? Awesome. So what we want to do is we want to take the radial pulse. We want to palpate just below the thumb and the medial to the anatomical snuff box. We want to be doing this for at least 15 seconds and timing it by 4. Okay, so is a pulse rate of 72 good for you? Yep. Awesome. So now we're going to do hemorrhage control. So first of all, we want to expose the wound. And we've got our non-adhesive dressing. And what we want to do is we want to fold it down to the smallest size so it still covers the wound to add more pressure. And then we spray it with a bit of saline just to make it moist so that if nurses need to see it, that they can not rip the wound. So we're going to apply this on. We want to put this on with either a crepe bandage or a triangular bandage, and for today I'm just going to use a crepe bandage. So we want to start from the bottom, working our way up. Now we can do figure of 8 over the wound. And what we can also do is when we start getting to the point that we need more pressure, we can twist the bandage over the top of the wound and apply more direct pressure. Now if this person were to keep on bleeding, we could apply another bandage on top and see how that works out. Moving on from the normal hemorrhage control, we can have catastrophic hemorrhage control. And what we want to do is we want to apply a combat application tourniquet. So we want to put this around the patient's arm, proximal to the wound, and use a single D loop. Now once this is tightly on, we want to twist the windlass until there is no radial pulse felt or the bleeding has stopped. Okay, then we want to put this tab down and we want to write the time that we have put the tourniquet on, and if the patient is conscious we want to give some analgesics because it is very painful to the patient. So now we're going to move on to the C-collar or the cervical collar, and we want to apply the Nexus rule. So that's for the National Emergency X-Radiography Utilisation Study, and it's indicated for trauma unless there are no posterior midline C-spine tenderness, no intoxication, they're alert, no focal neurological deficit, and no distracting injuries. So first of all, I'm just going to get my co-worker here to just hold on to the head to keep the neck still. If the patient was awake, we would ask for consent. So first of all, I'm going to measure it up by lining the fingers from the mandible down to the shoulder here and measure it on the side. So he's irregular, so I'll just move that up, slide it up and lock it in. Now we want to make sure that we go up and under, make sure that we've got the collar right underneath Nanny's head or the neck, chin. And we're just going to bring it round. Trying to not move him as much as we can, making sure that it's nice and tight. What have you done here today?
So I fell over this morning and I fell on my arm.
You fell on your arm?
Yeah.
Okay, so when you fell, what sort of pain did you get around your arm?
Oh, it just like a real shock to the top of just under my elbow sort of thing.
Okay.
Yeah.
So what I suspect is you may have fractured your proximal radius. So you fractured probably around here because it's a little bit swollen.
Yeah.
So what we're going to do is we're going to splint up your arm, and I'll talk you through each process, and we'll give you a bit of pain relief for that as well. Okay? But before we do any of that, is it okay if I do all that? So I will be moving your arm and everything.
Okay, yeah.
Sweet, cool. So first of all, what on a pain scale of 0 to 10, 0 being no pain at all, 10 being the worst pain imaginable, what is your pain rating at the moment?
It's about an 8.
It's about an 8? Okay. So I can see that you've lost a bit of your movement there. Can you wiggle your fingers on both arms for me?
Yeah.
Now how painful is it for you to do it on your left arm?
It's pretty sore, yeah.
Pretty sore? Okay. So she doesn't have any unusual movements, crepitus, shock, irregularity or deformities. She's just got a bit of swelling on her arm and obviously loss of movement, and the pain is obviously there. So also we want to just be checking the neurological and cardiovascular integrity. So we want to be just checking the pulse. So I'm just going to check your pulse. So you have a nice strong pulse on that arm, and I'm just checking on the other arm to compare. You have nice even skin colouring on each arm, and the temperature is both warm to the touch. So we also just want to check for a capillary refill, so I'll just be squeezing the thumbs and checking both of those and to make sure that the perfusion's alright. We also want to just make sure, do you have any like weird sensations going up and down your arm at all? No tingles or anything?
Okay.
No, that's fine. Okay, so moving on now, we're going to administer some Entonox, so it's an analgesia. So it's for moderate to severe pain. So I've got a few questions for you. Have you been scuba diving in the last 24 hours?
No.
Do you have an allergy to it? Are you breathing alright? You didn't hit your chest when you fell or anything? No? And you can obviously obey commands because you're talking to me. And do you have your bowel movements been regular?
Yeah.
Yeah? Okay. So this is Internox, so it's a self-administering drug. So what we'll do in a second is we'll put this around your wrist, and then I want you to take 5 to 6 deep breaths on it, and then you'll start feeling the pain going away, okay? There are a few side effects though, so you might feel a bit nauseous, a metallic taste, a bit of euphoria, you might feel a little bit flushed, and then maybe some auditory disturbances as well, okay? So if I just grab your arm for a second, I'll just slide my hand under there, and you put that on your wrist, and take it as necessary. So when you feel like you need to, just take some nice deep breaths on it, okay? So I'm just going to put this down on your leg for a moment, okay?
Okay.
Just whilst I grab my spit. So what we're going to do is we're going to slide this under your arm first off, okay? So I'm going to lift it up. Just make sure that you're breathing in the Internox. Okay, 1, 2, 3. Just slide that in, under. Okay. Cool. So what I want to do now is I'm just going to grab a bandage and I'm going to wrap around it, okay? So we'll need to lift your arm up, but I'll try to keep movements as minimal as possible, okay?
Okay.
So, do you have any allergies or medications that we need to know about?
No.
When was the last time you had a meal as well?
I had lunch today.
You had lunch? What time did you have lunch?
About 12 o'clock.
About 12 o'clock? Okay. So we'll try and keep this nice and short, but because our bandage is long, it might take a little bit longer, okay? Now we put the towel in the box to make sure that there's a bit of padding for the patient. Okay, if you just pop that down a second, just need to re-roll up my bandage. There we go. So lifting up again. I know it's sore. We're nearly at the end. So what were you doing to fall over?
I just tripped.
You just tripped? Okay.
Yeah.
Now that you're sipping on the Internox, what is your pain scale now out of 0 to 10? Same as before.
Probably about a 5 or a 6.
A 5 or a 6? Okay, so it's dropped down a little bit. So what we're going to do now is we're going to move your arm close to your body, but first of all I'm just going to put this underneath, okay? So I'm just going to put this across your chest.
Okay.
And then I'm going to lift up your arm. Yep, breathe it in. And I'll move that across. And I'm just going to slide this under to the end. Okay, I'm just going to tie this up behind you, okay? So if you can relax your arm for me for a moment. Does that feel nice and supported?
Yeah.
Sorry if I get your hair in here. We'll just tie up the end. So I'll just slide this across slightly. There we go. So lastly, we're just going to check that neurological and cardiovascular integrity again. So I'm just going to check your capillary refills. On both hands. The perfusion is still nice. I'm just going to check your pulse again. Just supporting under the arm. Still a nice, strong, steady pulse. Can you still wiggle your fingers for me? And there's still no sensations or anything? And on a pain scale of 0 to 10 again, what would you rate your pain now?
Around 4 or 5.
Awesome.
So we have approached a guy who, or an 85-year-old male who has complained of chest tightness, and as we got here we checked for danger and he had collapsed onto the ground, so we're checking for a response. Hello, hello, can you hear me? Hello, hello. So he's not responding, so I'm just going to check the airway, making sure there's no obstructions. There's none that I can see, so now I'm going to check for breathing by listening and feeling for 10 seconds. He's not breathing. So Nadine, can I get you to start compressions? Just going to Go on the radio. This is AUT requesting an R50 for an R49. So while she's doing compressions, I'm going to attach the defib pads. Just working around you here, okay? So don't mind me.
Analyzing heart rhythm. Do not touch the
Just
patient.
want to come off the patient.
Shock advised. Charging.
So now we're touching
Stay
the patient.
clear of patient.
Standing clear.
Deliver shock now.
Shocking
Press the
now,
on
stay
button
clear.
Now. Shock delivered.
Shock delivered.
Pause.
Get back on the chest.
Start CPR.
So while she's doing that, we want to set up our bag valve mask. Now once this is set up, just let me know. I'll insert an OPA and we can do those breaths. We want to make sure that the bag valve mask has a flow of 10 to 15 litres per minute throwing through it. Just doing that. Just going to insert an OPA. Okay, when you're ready.
28, 29, 30.
Just watching for chest rise as we're doing the 2 breaths. Now when we're doing our CPR, we want to ensure that we are doing 32 at a rate of 100 beats per minute. We also want to make sure that we're doing at least 1/3 of the chest depth.
30.
We also have suction here in case the patient does vomit during CPR.
27, 28, 29, 30.
We also want to make sure that when we're using the bag valve mask, we don't want to overinflate the chest, as we'll get reflux from the stomach as the air will escape down into that passageway.
27, 28, 29, 30.
Stop CPR. Analyzing heart rhythm. Stay clear of
So
patient.
we'll rotate now.
Analyzing heart rhythm. No shock advised. Pause. If needed, start CPR.
So no shock advised. Twenty-seven, 28, 29, 30. Twenty-seven, 28, 29, 30.